Go
This
ahead
conference will now be recorded.
and I will go ahead and turn the controls over to Dr. Durado Brooks. Give me 1 second here. Okay, Dr. Durado Brooks, you do have the controls, so whenever you are ready, you can go ahead and begin.
All right, let me pull up my slides in slideshow mode. Okay. All right. Well, thanks so much for the opportunity to speak to this group, and I'm going to be talking today about improving colorectal cancer screening. Got a lot of information to cover, so I'm going to dive right in. Why are we talking about colorectal cancer? Well, as Eugene just mentioned, it is Colorectal Cancer Awareness Month. We're right at the end of the month, but the disease deserves a month because it is the second most common cancer killer in the US, with more than 51,000 deaths expected this year, and more than 145,000 people are going to hear the words, "You have colon cancer," or "You have colorectal cancer," from their doctor just this year. The good news is more than 1.2 million Americans are either living with the disease and still fighting it, or in many instances have been treated very effectively and been able to get on with their lives. We do know that the risk varies significantly by race and ethnicity, and we'll talk about some of that data. Now, this is what's been going on with colorectal cancer deaths in the US going back over the last 40 years. And as you can see, it's been falling throughout that time, but particularly in the most recent decade between 2000 and 2011, a 27% drop in colorectal cancer deaths during just that single decade. Now, unfortunately, as with many things in the US and healthcare, things are not the same for every racial and ethnic group. You see the lines are trending downward for most of the groups in the US. That red line at the top is the African American population, who for many years were said to be the group that had the highest rates of colorectal cancer, and their rates are coming down. The blue line is the white population, and then down at the bottom, the yellow and green, those are Hispanic and Asian American populations. And again, lines are trending downward for everyone, but except right there in the middle, that zigzag line going up and down, that's the American Indian Alaska Native population. Now, I will say that those zigs and zags aren't because the rates are changing that dramatically from year to year. Much of it is really about data. And until the last few years, we haven't had a lot of good data on American Indian Alaska Native populations, but that data is improving. And unfortunately, the data that we do have indicates that, contrary to all other groups in the US, rates are actually going up for colorectal cancer deaths among American Indian and Alaska Native populations. Now, where we are seeing improvements, why? Why are we seeing those improvements? Part of it has to do with better treatment. We're able to treat the disease much more effectively now than we did even 20 years ago. Our radiation treatments have improved, our surgical techniques, and in particular, we have chemotherapy agents, Erbitux, Avastin, and other agents that allow people to live much longer or to eradicate the disease entirely in some cases. Certainly, though, screening plays a big role in in better survival and lower incidence of disease. When we find this disease early, as indicated on this little picture here, to the far left, you see stage 0 and stage 1, where the disease has not yet penetrated the colon wall. Patients have a much greater likelihood of surviving for a long time than if you get to stage 4 there on the far side, where you've got large cancers within the colon and those that are going through the colon wall and spread to other parts of the body. Indeed, for people who are diagnosed, okay. For people who are diagnosed with colorectal cancer in the early local stage, that's stage 0, stage 1, more than 90% of those people are going to be alive 5 years later. So again, with local disease, more than 90%, 9 out of 10 people will survive 5 years or longer. In many of those cases, people have their disease completely eradicated and get on with their lives. On the other hand, if the disease has spread to other parts of the body, less than 13, 14% of those people are going to survive for 5 years. So a huge difference in survival based on stage at the time of diagnosis. Now, in addition to helping find the disease early and treat it more effectively, screening also prevents colorectal cancer. If we find and remove polyps, we can keep people from ever getting cancer. And it's estimated that over the last 30 years, more than 500,000 cases of colorectal cancer have been prevented through our screening effort. Now, anybody who's interested in health issues in general among American Indian Alaska Natives and cancer issues in particular, if you haven't seen this supplement to the American Journal of Public Health from 2014, I encourage you to pull it up. I think it's the entire issue is now available online without, you don't have to have membership in APHA or anything. You can just go pull these articles, and it is the best overall summary of health issues and in particular cancer issues in the Native American and Alaska Native population that I have seen. Again, the data is a little dated because this was published in 2004, and as you'll see from some of the subsequent charts that I pulled from that, the actual data goes back to, I believe, 2005 to 2009. So anybody in the research world out there, this would be a good time to start trying to look at this data again, because I'm sure that there have been some interesting changes. I'm sure that most or all of you on the line are familiar with the CHSDA counties, the contracted health services. This is a way that the Indian Health Service breaks down the country in order to track various issues and trends. So that's how this data is broken out. This is colorectal cancer incidence. So the proportion of folks who are getting the disease, with the dark bars being the American Indian Alaska Native population and the light pink bars being the white population within those same parts of the country. And as you can see, colorectal cancer incidence in Alaska for Alaska Natives is more than twice that of the white population. So chances of being diagnosed with colorectal cancer if you are an Alaska Native are more than 2 times as high as your white counterparts. For other parts of the country, you can see that overall the rates are significantly higher, except in the east and the southwest, where Native American populations in those parts of the country actually have a slightly lower likelihood of being diagnosed with colorectal cancer. The reasons for these differences, these regional differences, are not clear at all, unfortunately, but they do have some real impact. This is mortality, so the likelihood of dying from colorectal cancer. And again, you can see that in Alaska, if you're an Alaska Native, you're more than twice as likely than the white population to die from colorectal cancer. And you see that death rates, again, are significantly higher in most other parts of the country. And notice that even in the East region, where incidence rates, the likelihood of being diagnosed, are lower among the Native American population, if you're diagnosed with colorectal cancer, your chances of dying are higher if you are an American Indian. So there's clearly some significant issues, likely related in part to access to care, related to screening, related to a variety of other things. So only in the Southwest are American Indians less likely to die from colorectal cancer than the white population. And again, we don't know why. We don't know why we see these kinds of regional variations, but there's work going on trying to figure out what those differences are. Now, one of the things that we know accounts for some of these differences, particularly in death rates, are differences in screening rates. In 2016, across the US, 67.3, basically 2/3 of people were up to date with colorectal cancer screening. However, rates are significantly lower for Native American populations, as well as for Hispanics and Asian Americans. Regardless of race or ethnicity, screening rates are lowest among people who have low educational levels, low income, and the uninsured. And then in Alaska, for many years, the rates were significantly lower for the Alaska Native population. However, in recent years, there has been a significant improvement, although the Alaska Native rates are still below those of the national average, still haven't hit that 67.3%. These are screening trends in Alaska, and you can see going back to 2008 that there was a significantly lower screening rate among Alaska Natives than for the state population overall. But you also see that actually difference disappeared, and for a period of time, rates among Alaska Native people was actually higher than among the general Alaskan population. Much of that rise is attributed to the fact that the Centers for Disease Control was funding 2 different colorectal cancer screening improvement projects in Alaska during this period when we saw that increase. Unfortunately, that funding has gone away. The infrastructure that was developed during that time, some of it has sustained, and consequently, rates for Alaska Natives have not fallen too far, but they're not climbing at the rate that they were back when that CDC funding was available. But when you look across the rest of the country at overall colorectal cancer screening rates, there are significantly lower rates among most of the Native American population. Again, here at the far left, you see Alaska, and those rates being over 60%. No one else is over 50%. I guess in the Oklahoma region, they're right around 50%. Now, recognize that the national goal was established by the American Cancer Society and the National Colorectal Cancer Roundtable back in 2014 of achieving an 80% screening rate. So all of these rates fall significantly short of that. You can also see that the Great Plains region, which is representative, I'm sure, of many of the folks who are on the phone, those rates are particularly low. Second only to Phoenix. The Phoenix region has the lowest screening rates. But at any rate, screening rates of 30 to 50% among the American and the Alaska population are a big problem, given that I've already told you that incidence and mortality rates are higher than that of the general population. So we really need to get these screening rates up if we're going to make a big difference in long-term outcomes. Now, this is the trends that we've seen in colorectal cancer screening based on GIPRA data. And as you can see, back in 2012, the nationwide, the rates were reported to be about 46%, but then they dropped off. This is likely not a true drop off in screening rates. It's probably changes in the way that the data was collected and likely more accurate numbers. So that 46% was probably an overestimate in terms of national rates. But since 2013, you see that each year there's been a small but steady increase all the way up to 2017, where the screening rates nationwide are up to a 40% average, or 41.4% average. The national target, I should point out, from IHS was 40.2%. So they actually beat that target. But as I said, for the rest of the nation, as overall, our target is 80%. So we're still far, far short of that 80% goal. And I'm going to talk a little bit about ways to help move that marble. Now, how do these rates play out? If you look at outcomes from colorectal cancer, as I mentioned earlier, earlier stage disease means better likelihood of survival. Later stage disease, a much lower likelihood of surviving. And as you can see, early stage disease represented by these sort of lemon or yellow orange bars, much lower rates of early stage disease in the American and the Alaska Native population, and higher rates of late stage diagnosis in those groups. So screening undoubtedly is playing a role in this increased likelihood of late stage disease. So let's talk about screening. Let's talk about guidelines and screening tests. Now, much of what I'm going to be saying is going to be focused around the average risk population. But it is important to know who is not at average risk, because screening recommendations are different for people who are at increased or high risk. There are a number of personal risk factors that put you at high risk. Personal history, if you've had adenomatous polyps or if you've had colorectal cancer in the past, your risk is higher of developing it again. Also, people with Crohn's disease or ulcerative colitis are at higher risk. Family history is also a very important issue. And in most environments, when you go into a doctor's office and they'll ask about a family history, they'll ask about a family history of cancer, but also family history of adenomas is very important. If your mom, dad, sister, or brother had at least one adenomatous polyp found at some point, that means that your risk is twice that of the general population of developing colorectal cancer. So family history of adenomas should trigger earlier screening, but it's a question that is too seldom asked. And then there are a variety of hereditary syndromes, Lynch syndrome, familial adenomatous polyposis, and others, all of which again increase the likelihood of being diagnosed with colorectal cancer and being diagnosed early. So for people who have any of these risk factors, they need to start screening at a much earlier age. If mom had colorectal cancer at age 51, that means your patient now needs to start screening at 41 or 10 years before mom's diagnosis. But in order to make those recommendations, that means you need to be doing a careful family history and risk assessment. These are guidelines for colorectal cancer screening from the U.S. Preventive Services Task Force. And these guidelines were last updated in 2016. Excuse me. And up until May of 2018, these guidelines were essentially identical to those of the American Cancer Society. Now, the Alaska Native Medical Center, a number of years ago, actually, because of the very high rates of colorectal cancer that I showed you earlier in the Alaska Native population, began recommending screenings for average risk Alaska Natives starting at age 40. And so a number of places in Alaska have been doing this earlier screening for a long time. In May of 2018, the American Cancer Society published updated recommendations for colorectal cancer screening, and we broke with the tradition of recommending screening starting at age 50 for all average risk people. I will say that up until May of 2018, most major organizations that deal with screening guidelines nationwide recommended screening at age 50 for all average risk individuals. And we did not take this measure lightly. The ACS spent a lot of time, energy, effort, and resources to really dig deep into the literature and the evidence. And we, after all of that extensive review, feel very confident that 45 is the new 50 and that starting screening at age 45 is the best option to help change the trajectory of colorectal cancer in the US. I'll be talking about some of the evidence that led us to that conclusion. Another important element that we pointed out is that there has been some increase in the use of non-colonoscopy screening test, particularly stool test, to improve colorectal cancer screening rates. However, one of the shortcomings of this issue is if someone has a positive stool test, they absolutely must have a colonoscopy in order to determine whether that stool test is indicative of cancer or polyps or some other colon disease. However, in many settings, that follow-up colonoscopy is not being done, or at least not being done in a timely manner. So our guideline also points out the importance of making sure that follow-up colonoscopy is available. So our guideline basically states that for average risk adults in good health, they should start screening at age 45 and continue screening through the age of 75. We also indicate that for individuals between ages 76 and 85, the decision to continue screening should be individualized. And that's because not every 76-year-old is created equally. There are some people who at 76 have multiple health issues. They are not likely to survive for another 10 years or indeed even another 3 or 4 years, and therefore putting them through the rigors of a colorectal cancer screening and follow-up and colon cancer treatment is not likely to benefit them. On the other hand, there are some people who are in their late 70s or early 80s who overall are very healthy, and having such a person be diagnosed and ultimately die from colorectal cancer is a tragedy. So we really need to look at patients' overall life expectancy, their current health status, and also their screening history. If someone is 76 years old and has had regular colorectal cancer screening for the last 20 or 25 years and never had any abnormalities show up, then there may be little benefit in continuing. On the other hand, if someone was screened at age 55 and they haven't been screened again and they're now 76 and relatively healthy, then there's a good chance that screening could be beneficial, much more beneficial than harmful. So individualizing the screening decision is the important issue there. And then finally, over age 85, there's really no evidence supporting regular screening in that age group, so we discourage screening. With regard to which tests should be used, there are a long list of tests, and frankly, these tests are the same as those that are in the guidelines from the U.S. Preventive Services Task Force that I showed you earlier. And all of these tests have some evidence supporting their value, but there are some tests that are used much more often than others, and I'll be talking about those later. Again, reinforcing the importance, if any test other than colonoscopy is used for the initial screen, if that non-colonoscopy test is positive, then the patient absolutely has to have a follow-up colonoscopy. So side-by-side comparison with ACS and Preventive Services Task Force, really the only significant difference is starting at 45 based on ACS recommendations. So why did we break with tradition and go in that direction? Well, the U.S. Preventive Services Task Force actually commissioned studies, modeling studies, before they published their guideline, and to assess the appropriate age to start screening, as well as benefits and outcomes associated with screening. They had 3 different models, and 2 of those 3 models from the Preventive Services Task Force actually recommended screening beginning at age 45. However, because the 3rd model differed and because there was not a lot of direct evidence, that is, a lot of evidence that has been collected in people age 45 for screening, the Preventive Services Task Force opted not to go in that direction. Now, the ACS used these same models and the same modeling groups, but we had new data. We had data that had not been published at the time that the task force was doing their evaluation. And plugging in this new data, we came up with some different outcomes. In addition, we looked at this data from the standpoint not just of age, but also looked at it from the standpoint of gender and racial and ethnic data. But really, racial and ethnic was limited to Black and white because we didn't have enough good long-term data for other populations to make those assessments. I mentioned new evidence. One very startling piece of evidence that was published after the Preventive Services Task Force guideline came out was information demonstrating that there has been a 51% rise in colorectal cancer incidence before the age of 50 over just the last 25 years. So between 1994 and actually, I think this went up to only about 2012. So over that 22-year period, a 51% increase in colorectal cancer in people aged 20 to 49. Most of this increase actually occurs in people between the ages of 40 and 49. However, there is a rising number of cases of colorectal cancer in people in their 20s and their 30s as well. Rectal cancer is increasing more rapidly than colon cancer, but both are going up. Looking at the proportion of people diagnosed before age 50, back in 1990, 6 out of 100 people who were diagnosed with colorectal cancer were under the age of 50, so 6.4%. By 2015, 25 years later, that number had essentially doubled. So now 12 out of every 100 cases of colorectal cancer in the US are diagnosed in someone under the age of 50. In 2018, it's estimated that about 16,450 individuals diagnosed with colorectal cancer in the US were under age 50. 16,000 cases. And one of the other things that we know is 43% of these cases of people diagnosed before age 50 are among people in that 45 to 49-year-old group, the group that is targeted for colorectal screening in the updated ACS guidelines. So one of the big hopes is by screening people earlier, we will either prevent some of these cases of early onset disease or find many more of these cases in early stages where our treatment's going to be more effective. I said earlier, 45 is the new 50. One of the things that we did, we looked back at what the incidence rates for colorectal cancer were in the US back at the time that that screening guidelines really prompted a change in behavior, and we started screening more people for colorectal cancer. So in the late 80s, early 90s, the incidence rates for colorectal cancer were just a little bit over 30 cases per 100,000 individuals at age 50. If we look at the incidence rate now at age 45, the incidence rate for colorectal cancer is about 30 cases per 100,000. So the same incidence rate that led us to start screening people back in the early 90s, we are now hitting that incidence rate at age 45 instead of 50. So 45 is indeed the new 50. And if that incidence rate was sufficient to say we needed to start screening people back in the 1990s, well, we've hit that same incidence rate for 45-year-olds. So why shouldn't we start screening people at 45 instead of 50? As I mentioned earlier, all sorts of trends in the US tend to vary based in part on race and ethnicity. You can see that the under 50 diagnosis trends are in that same group. The blue line is the white population, and you can see the rates are steadily heading up as they are for just about every population. However, that orange line at the top, that's the American Indian Alaska Native population. And as you can see, rates of under 50 diagnosis in that group in particular are outrageously high and going up very dramatically and steadily. This is data from that APHA article or journal that I mentioned earlier. This is going back to the period from 1990 to 2009. And as you can see, among American Indian and Alaska Native populations, under 50 diagnosis, the red portion of this bar was more than twice that of the non-Hispanic white population. So going as far back as 2009, 20% of cases among American Indian and Alaska Natives were under age 50. So there is concern that the rates may be even higher than this. But again, all the way back 10 years ago, rates were already twice that or more than twice that of under 50 diagnosis in American Indians versus the white population. Now, I also want to point out, though, that it's not just age 50 that we see a problem. And when you look at the data more closely, over the age of 55, we're seeing very steady falls in both colon and, to a lesser degree, rectal cancer. However, between ages 50 and 54, colorectal cancer rates are colon cancer rates are actually steady or maybe creeping up, and rectal cancer rates are climbing. So it's actually at age 55 that we start seeing a very steady and sustained fall. Part of that, we believe, is related to this fact, and that is less than half of people between age 50 and 54 are up to date with screening. So even though screening has been recommended for people age 50 and older for more than 20 years by essentially every major public health group in the US, less than half of people at the early end of that screening segment are actually being screened. As a matter of fact, one of the ACS researchers included a note just the other day. This is not published data, I don't believe, but the average age at which people actually start getting screened in the US is somewhere around 58. So we are, even though recommendations have been to start screening at age 50, for some reason there is a huge delay in actually getting the uptake of screening. And it is our hope that recommending that screening start at age 45 will prompt people to start at least having that discussion at 45, and maybe by 50 we'll have a more significant portion of the population screened. This is another way of looking at the data, but this is actually for individuals under age 55. You can see that back in 1990, 13% of individuals diagnosed with colorectal cancer were under age 55, and by 2013, that number had risen to 20% under age 55, and that's for the general population. So why? We know that the rates are going up, but do we know why? And the sad reality is we really don't know, but there are a lot of different potential causes. We know that obesity, red meat intake, type 2 diabetes are all risk factors for colorectal cancer. And we know that the rates of all of these have been going up pretty steadily for the last 30 years or more. And these may be contributing. As a matter of fact, there was a recent publication that looked specifically at obesity in women and linked it very closely to early onset disease in women. In addition, antibiotic use. We have a lot of antibiotics, kids getting antibiotics for every cough, cold, runny nose. There's antibiotics used in livestock to help them grow more. And all of these, are ending up in the human body. There are a lot of bacteria in the human body, including in the gut. And it is now known that some of those bacteria actually are protective, and some may be protective against cancer. And when we start changing that gut microbiome, we may be increasing colorectal cancer risk. Then there are other things that we just don't have a good handle on. So again, the reality is we don't know the reasons behind these and behind the rise that we're seeing. We do know the rise is real. And in all likelihood, it is a combination of risk factors, some of these included here, and other factors we haven't identified yet. So what do we do about it? Well, number one, we identify those people who we know are at increased risk. In most studies, somewhere around 25% or so of people diagnosed before the age of 50 actually have risk factors that should have led them to start screening at an earlier age, but those risk factors weren't identified until the patient developed colorectal cancer. In this study, the number was even higher than 25%. 44% of these patients who were diagnosed before age 50 and treated at this university clinic, 44% has risk factors that should have led to earlier screening. And these risk factors, a first-degree relative with colorectal cancer, a first-degree relative with an adenoma, at least one adenomatous polyp. That was 30% of their population had those risk factors, but those risk factors weren't identified. And then another very significant portion of that population had genetic syndromes that, had a good family history been taken, could potentially have been identified. So with regard to identifying those risks, the American Cancer Society and the National Colorectal Cancer Roundtable teamed up to produce a guide on risk assessment. So for any of you all in primary care environments in particular, this has a lot of tools, resources, and guidance on how you can better assess your patient's risk and then respond appropriately to those folks who are at increased risk. Again, about 25% of cases of people diagnosed before the age of 50 might have been avoided if their risk factors had been identified and they had begun screening earlier. The other thing that is very common, however, is that younger patients often have symptoms for weeks, months, or years before they seek treatment, or sometimes they seek treatment and their doctors tell them, oh, you're way too young for colorectal cancer. Don't worry about that. You must have hemorrhoids. It must be an ulcer. I talked to a lot of young patients, a lot of people who were diagnosed in their 20s and 30s, and almost every one of them has had that experience of their symptoms being minimized by healthcare professionals. So gone are the days that we can look at someone and say, oh yeah, you're too young for colorectal cancer. Don't worry about that. We have increasing rates in people in their 20s and their 30s. So if you have patients who show up with rectal bleeding, abdominal pain, weight loss, changes in bowel habits, any of those kinds of symptoms lasting for more than a week or two, you need to take those symptoms very seriously. And the fact that we recommend colorectal cancer screening starting at age 45 or 50 is irrelevant when it comes to a patient with symptoms. Screening is something you do for people who have no signs or symptoms of disease. Once symptoms develop, screening recommendations go out the window. So you have to look at people's symptoms and respond appropriately. Now, going back to screening, the commonly used screening tests, we have a lot of different tests, as I showed you earlier. The most commonly used tests are colonoscopy or stool test, and in particular, stool tests that look for hidden blood. So I'm going to talk about each of those. Colonoscopy, a long lighted tube, camera on the end, looks at the colon from stem to stern, and has some real advantages because it is a screening test. It's also diagnostic. If something unusual is seen, you can pick off a piece during the colonoscopy and send it off to the lab and find out what it is. Or if a polyp or some other growth is seen, usually it can be removed during that same procedure. So it is therapeutic. So it is screening, diagnostic, therapeutic, all rolled into one. In addition, if the colonoscopy is completely normal, then it doesn't need to be repeated for 10 years. So you don't need to do any other form of screening. There's no point to doing stool testing after a normal colonoscopy. Now, if a patient develops symptoms after a normal colonoscopy, so colonoscopy is read as completely normal now, and 2 years from now, a patient develops rectal bleeding that's not clearly hemorrhoidal, then that patient needs to be reevaluated. You may need to do another colonoscopy because colonoscopy will miss some things. It's frequently referred to as the gold standard, but it's not a perfect test. And in studies from a few years ago, colonoscopies missed up to 10% of polyps and also some cancers. It also costs much more on a one-time basis than any of the other screening tests we have available. It is more likely to injure a patient. It's a safe test overall, but somewhere in the range of 1 in 500 to 1 in 1,000 individuals who undergo screening colonoscopy will end up with some complications. Sometimes it's a little bit of bleeding and they end up in the emergency room. Sometimes a lot of bleeding. They have to have a transfusion. Colonoscopy can also lead to a hole in the colon, a perforation, and it can lead to cardiovascular and cerebrovascular events like strokes and heart arrhythmias. Again, because we're doing this test oftentimes in people in their 60s and 70s, and they may have underlying health issues. And then finally, colonoscopy quality is extremely variable in the U.S. There are a number of quality measures that have been developed, and are recommended by all of the major GI organizations. And the most prominent of these right now is something called the adenoma detection rate. The adenoma detection rate is the proportion of patients who are in whom at least one adenoma is found. And it turns out adenomas are really, really common. And the standard today is that if you are doing colonoscopy in a average risk population, you should be finding one adenoma in 30% of men or at least one adenoma in 20% of women. So if you're seeing a mixed gender population, you should basically be finding at least one adenoma in 1 out of every 4 patients that are being scoped. Yet in a number of studies, it's been demonstrated that gastroenterologists and surgical endoscopists have very wide variation in who does a good job in finding these adenomas. Some find adenomas instead of 1 out of every 4 patients, only in about 1 out of every 10. And then there are some who find adenomas in half or more of the patients that they scope. And it turns out that this adenoma detection rate is also a predictor of patient outcomes. This study and a number of other studies have looked at this and found that patients who are treated by doctors who have the highest adenoma rates are less than half as likely to be diagnosed with colorectal cancer in the near future than those who are treated by doctors who have poor or low adenoma detection rates. And patients who are treated by doctors who have poor adenoma detection rates are nearly 3 times as likely to die from colorectal cancer in the future than patients who are treated by those doctors who have the best adenoma detection rates. So this is a very real and very concerning number. And if you have the option, if you have different endoscopists that you can send your patients to or that you yourself can go see, ask the doctors, ask their practices about whether they're collecting this quality data and whether or not they have information on their adenoma detection rates. That's how you make a selection based on quality. The colonoscopy has some additional challenges. It requires that patients go to another facility in most cases. They have to go see another doctor, go to another facility. They have to do the bowel prep, which many patients find very challenging. It just adds a real hassle factor. And then for many folks in the Indian country, it may be a long trek to get to a colonoscopy, 2-3 hours just to get to the procedure. And then finally, while many primary care doctors very strongly favor colonoscopy and have a strong preference toward it, for a lot of patients, they don't want that kind of invasive test. This study looked at over 1,200 patients, all of whom were due for a colorectal cancer screening. And after educating all the patients, they asked patients what they wanted. They asked some of the patients what they wanted. Some patients were just told, go get a colonoscopy. Another group was told, take these kits home, collect stool specimens. And then a third group was asked, you want a stool test or colonoscopy? You choose. At the end of the study period, 38% of patients who were offered a free colonoscopy actually got screened. So less than 4 out of 10 patients got screened with colonoscopy. 2/3 of patients who were only offered stool testing got screened. And 2/3 of patients who were given a choice got screened. And more patients who were given a choice chose stool testing. So let's talk about stool testing. Modern stool testing is mainly with fecal immunochemical tests, which are also called FIT test or IFOB. And these tests are specific for human blood. So you get much lower false positive rates. There are no foods or medications that are known to cause either false positive or negative test results. And many of the FITs only require collecting 1 sample or at most 2 samples compared to older guaiac tests, all of which require 3 samples. FIT also are much more sensitive for cancer. In this meta-analysis, it looked at a lot of different fecal immunochemical tests. On average, they had about a 70% sensitivity for cancer. Most studies of guaiac tests indicate that they have about a 20 to 25% sensitivity for cancer. So you're much more likely to find cancers with FIT-based screening than with guaiac testing. When the Preventive Services Task Force updated their guidelines, I mentioned the modeling studies they did. One of the questions they asked modelers was, how many lives can we save if we screen people by different methods? COL10Y at the far right of this slide is colonoscopy every 10 years. These modelers estimated that for every 1,000 people screened with colonoscopy every 10 years, 24 deaths from colorectal cancer would be prevented. That's a really, really good investment. There aren't many things we do in medicine where for every 1,000 people you treat, you save 24 lives. On the other hand, the other side of the slide, FIT1Y, that's doing FIT testing every year. 22 deaths from colorectal cancer can be avoided using every year FIT testing. So 24 is better than 22, but when you start looking at big populations, tens of thousands, hundreds of thousands of people, that difference really diminishes. And so FIT testing actually is the main approach to colon cancer screening around the world. Outside of the US, there are few, if any, other countries that use colonoscopy as their main approach to colorectal cancer screening. Now, there are some important points about stool testing to keep in mind, though. One, they are only for average risk. So patients who have the family history or other issues, you need to weed them out, and those folks still need to go directly to colonoscopy. You have to use high sensitivity stool testing, which in most cases means FIT. And you have to do that careful follow-up, make sure everyone with a positive FIT gets a colonoscopy. The specimen also has to be collected appropriately. In many settings, I still hear about primary care clinicians doing digital rectal exams and then smearing a specimen on a card and saying that patient is up to date with screening. That is not colorectal cancer screening. The largest study that looked at using digital rectal exam samples for stool testing found that 19 out of 21 cancers that were present at the time of that rectal exam had negative digital rectal exam stool specimen findings. So any test that misses 19 out of 21 cancers is not an appropriate test. All this information I've just shared about stool testing and high quality stool testing can be found in this 5-page brochure. And you can find this at the American Cancer Society website or at nccrt.org. I wanted to spend a moment also talking about a new kid on the block, and that is stool DNA testing. Now, the test I've talked about up to this point, FIT and guaiac test, both rely on the presence of blood. Stool DNA tests are different. All they rely on is the fact that as stool moves through the colon, it knocks some colon cells off the wall of the colon. And the makers of this test have figured out how to interrogate those colon cells and look for DNA changes that are associated with polyps or cancers. So the presence or absence of blood for DNA testing is not relevant. It's really about colon cells. However, there's only one stool DNA test currently on the market in the US, and that is Cologuard. And Cologuard is actually a combo test. So it has these tests for DNA abnormalities, and it combines that with a high quality FIT test. So it's a twofer. You get both a FIT and a stool DNA test. Now, this is the largest study of Cologuard that's been published to date. This was over 10,000 screening colonoscopies, and all these patients collected stool specimens ahead of time and had them analyzed by FIT alone and then the FIT DNA combo, which is Cologuard. And what they found was FIT testing alone found 74% of cancers, or 73.8% of all the cancers that were present. So again, very much in line with what I mentioned earlier about that 70% sensitivity. However, when you add the FIT plus the DNA component, you got up to 92.3% sensitivity for cancer. And that was cancer at all stages. 90 plus, so better than 9 out of 10 cancers were detected. However, in addition, the FIT testing found about 23.8, almost 24% of polyps, or what they called advanced precancerous lesions. So these are the kind of polyps that had a high likelihood of progressing to cancer. And Cologuard found 42% of those. So you get better polyp sensitivity, but you still miss more than half the polyps with Cologuard, but 92% sensitivity for cancer. However, with that higher sensitivity, you get lower specificity. That is, you end up with more false positive tests. So more people undergoing Cologuard screening are going to end up needing that follow-up colonoscopy. So that's an important point to keep in mind. Now, this is actually, to my knowledge, the only colorectal cancer screening test that's been tested directly in a non-white population within the U.S. And that is Cologuard is now, I think they've published 2 studies looking at using Cologuard in the Alaska Native population, and they found that it works just as well among Alaska Natives as it does for the general U.S. population. So a number of things to know about Cologuard or FitDNA testing. It is included in the guidelines both from the American Cancer Society and the U.S. Preventive Services Task Force. It is cleared by the FDA to be marketed as a colorectal screening test in the U.S. It's recommended to be repeated every 3 years. And the reality is the evidence around this every 3-year interval is pretty limited. And it's my understanding that the company that makes Cologuard is now doing additional data collection and follow-up and tracking to try to figure out, is 3 years the right interval, or should it be every other year, or is it good for 5 years? But for now, the 3-year retesting interval is what's recommended. And Medicare and many private insurers now will pay for Cologuard once every 3 years. If an individual doesn't have insurance or their insurance doesn't cover it, it's my understanding that the tests cost about $600. So patients should be aware it is an option, but it is a somewhat pricey option. Again, every positive has to be followed with colonoscopy. And one thing to keep in mind is that actually for that price, relatively high price tag, in addition to getting the test done, there's also a patient navigation component provided by the company. That is, once the clinician writes the prescription for Cologuard and that goes off to the company will then contact the patient, make sure they've got the right address to mail out the shipment. They'll mail it to them, and then they'll follow up with them and try to get that kit back. So they get somewhere between a 60 and 65% return rate on that follow-up. For those of you who are doing fit testing in your practices, you'll recognize that a 60 or 65% return rate on a stool test is really quite good. And if you're getting that rate of return in your practice, that often means that you've got somebody, your nurses, nursing assistants, navigators, somebody is doing a lot of work to help remind patients and get that back. So the Cologuard companies take some of that responsibility off your plate to help get those tests back. Now, the American Cancer Society has been very focused in recent years on trying to help improve colorectal cancer screening in Indian country. And right now we have 5 grants in place in various places around the country to try to learn what works and what doesn't work to help boost colorectal cancer screening rates among American Indians, Alaska Natives. These grants will actually be coming to an end sometime this spring, and we will be doing a formal evaluation and collecting a lot of information from these centers, and hopefully in the future we'll publish a paper or some sort of a resource manual that can help other centers understand what was learned in these sites, and hopefully work to boost colorectal cancer screening rates in many other environments. So all of the information that I've talked about is available at the website here at the top, cancer.org/MD. And then there's information about not just colorectal cancer, but all other kinds of cancer issues, as well as tools and resources for your practices and for your patients that can be found on our more general site, that is cancer.org/professionals. And these are also available on your mobile device. So with that, I am going to turn it back over to Eugene and Chad, and click to exit. There we go. And I think I've got just a couple of minutes if there are any questions.
Thank you, Durado Brooks. A lot of jam-packed information, so if anyone has any questions, please feel free to ask them now. Or if you don't have a microphone, you can go ahead and drop your questions into the chat box.
All right. I see one question in the chat box. What's the guidance if someone has a positive Cologuard and negative colonoscopy? That's a really good question. The issue has been looked at actually by the company that makes Cologuard. And it turns out that the same kinds of markers that can indicate colon cancer or polyps also are associated with a number of other issues. In the early years of DNA stool testing, they used to send people for very aggressive workups with upper endoscopy and all sorts of scans. And it turns out that they very seldom found anything of significance. So right now it's recommended that colonoscopy is normal and that the colonoscopy is a high quality exam, that no other evaluation is necessary unless that patient becomes symptomatic in the future. So the patient is, if they have a positive Cologuard and a normal high quality colonoscopy, they don't need any other screening for 10 years. Let's see, other questions. Well, thank you all for the positive comments. I see, can we get a copy? And yes, I'm sure that Eugene and Chad can make the slides available.
Yeah, so we will have a copy of the presentation itself, and also the presentation was recorded. So if anyone would like a link, we can provide that recorded link for the presentation. So, is there any more questions? So if we don't have any more questions, again, I'd like to thank Durado.
I heard somebody talking, Eugene. I don't know if that's on your side or was someone asking a question. Hi.
Is there any more questions that anyone would have for Durado Brooks in the presentation?
Apparently not. All right. Well, if any questions come up, I'm sure that you all can forward them to me and I'll do my best to provide a timely response.
Awesome. Thank you, Durado Brooks. I appreciate it.
All right. Thank you all. And I really appreciate the chance to speak with this group.
Thank you.
Thank you.